Hello everyone, welcome back. I'm Dr. Shariful Ali, but today I'm going to talk about a very important topic, very conceptual topic, which is acid-base disorders. Okay, so the basics here, I have written it. I have took it to get you an overview of the acid-base disorders. So you have actually four main acid-base disorders: metabolic acidosis, alkalosis, respiratory acidosis, and alkalosis. So four main disorders: two are metabolic and two are respiratory. And actually combine, or you can actually integrate this thing with two substances. One is carbon dioxide and another is bicarbonate. So any problems with bicarbonate will be metabolic problem, and any problem with carbon dioxide will be a respiratory problem. So this is the basic. Okay, and consider carbon dioxide as an acid and consider bicarbonate as a base, and consider that your body always have an equilibrium between acid and bicarbonate, or your body wants to have an equilibrium. Okay, so whenever something is changed, the other thing will be changed in the same way. Okay, so this is the basic rule. Okay, next, so whenever someone has a decrease in bicarbonate level, first of all, bicarbonate level is a metabolic problem. So if a decrease in bicarbonate level will decrease base, and the patient will have acidosis. And what type of acidosis? A metabolic acidosis. And as I've already mentioned, that the bases and acids go up or go down to keep in an equilibrium. If you have a decrease in bicarbonate, you actually want to decrease your carbon dioxide, and you can do the decrease in carbon dioxide by actually hyperventilating and releasing more carbon dioxide from your lungs. Okay, and then if you have an increase in bicarbonate, this is a base, there will be excess of base, it will be called an alkalosis, and you want to actually get an equilibrium. And to get an equilibrium, you want to increase the level of carbon dioxide, and you can do that by actually reducing your respiratory rate, so hyperventilation, which will lead to accumulation of carbon dioxide in your body, and ultimately maybe you can achieve an equilibrium between carbon dioxide and bicarbonate. Okay, so the metabolic problems, and then the respiratory problems. If you have an increase in carbon dioxide, you will be calling it a respiratory acidosis. So if you have an increase in acid, you want to increase the base, so you want to increase the bicarbonate, and the way you can do it by increasing bicarbonate reabsorption from your kidney. And also, if you have a decrease in carbon dioxide, you will be calling it a alkalosis, respiratory alkalosis. So as the carbon dioxide is decreasing, you also want to decrease the base, so you want to decrease bicarbonate, and actually this will lead to a possible equilibrium in your body. So we can decrease the bicarbonate by increasing excretion through kidney, and you can do that by decreasing reabsorption of bicarbonate in your kidney. Okay, so that should tell you the basic concepts. Next is anion gap. Anion gap is all about unmeasured anions, or unmeasured anion can be anything. Any anion other than bicarbonate or chloride is an unmeasured anion, and you can actually calculate it by this formula. So sodium minus concentration of chloride plus bicarbonate is a formula for remembering, a very important formula. You can use it to calculate if a acid-base disorder is a normal anion gap acid-base disorder or a high anion gap acid-base disorder. Okay, so here we have a case. Mr. High, a 50-year-old diabetic patient, very important, and he has been unconscious for last 1 hour. And on examination, he has a respiratory rate of 30 breaths per minute, and his breath has a fruity smell. Okay, when you check the RBS, you've got a very high RBS, which is 30 breaths per minute, 30 millimoles per liter. And can you tell me what is the most likely acid-base disorder he is having? Very good, he is having a metabolic acidosis, and which is a high anion gap metabolic acidosis. Actually, this metabolic acidosis occurred due to excessive ketone body production in this diabetic patient, who actually got some infection, or maybe in some stress, which lead to excessive production of ketone bodies, leading to ketoacidosis. And as you know, ketone bodies are actually anions. So those anions will be included in the unmeasured anions, because it's not chloride or it's not bicarbonate, and anything other than chloride or bicarbonate will be called an unmeasured anion. And this unmeasured anion will increase the anion gap, so it will be called a high anion gap metabolic acidosis. Okay, so this is our first case. Next case, next is we just go through some important causes of high anion gap metabolic acidosis. So I have already mentioned the case, which is diabetic ketoacidosis, very important, and renal failure. Also, in renal failure, you can't actually excrete hydrogen as titratable acid such as H2PO4 minus, and also you cannot excrete hydrogen ion as NH4 or ammonium. So if you can't excrete hydrogen ion, it will build up in your body and will cause a acidosis. Okay, so there will be an acidosis. And some poisonings are also associated with metabolic acidosis, such as methanol poisoning, where you have increased formation of formic acid, ethylene glycol, where you have increased formation of glycolic and oxalic acid, and also salicylate or aspirin intoxication in severe cases can lead to lactic acid. Okay, and lactic acidosis can also occur in case of shock states, because if you have a shock, your body does not have proper amount of oxygen. That's why it switches off from aerobic metabolism to anaerobic metabolism and forms excessive amount of lactate, which leads to lactic acidosis. And remember that lactate is also an unmeasured anion, leading to a high anion gap metabolic acidosis. Very good. Next, so here we have a case. This is a woman who has a history of weakness, orthostatic hypotension, and recently she's having increased skin pigmentation. Suppose you can see here the angles of the mouth are increased pigmented, and the gums are also has increased pigments. Okay, on labs she has a decrease in serum sodium concentration and also increase in serum potassium concentration. So can you tell me what is the most likely acid-base disorder that she's having? Okay, pause for a moment. Very good. So this patient has a normal anion gap metabolic acidosis. Actually, I didn't tell you the diagnosis. This patient actually have hypoaldosteronism, or you can also tell it as Addison's disease, and where there is a lack of aldosterone, which actually causes a decrease in hydrogen excretion. As you know from your physiology, previous endocrine physiology, is aldosterone actually have three main functions of the kidney. One of them is increased reabsorption of sodium, and two is increased excretion of hydrogen ion and also potassium ion. So the aldosterone, if aldosterone is normal, there will be a normal excretion of hydrogen ion and potassium ion. But if you have a decrease in aldosterone, you can't excrete actually potassium and hydrogen. So hydrogen will build up, leading to metabolic acidosis, and potassium will build up, leading to hyperkalemia. And one another thing, hyperkalemia actually helps or contributes to acidosis also with the primary disorder of decreased hydrogen excretion, because if you have an increased potassium in your body or hyperkalemia, it will actually lead to decreased ammonia synthesis, and ammonia actually is a carrier for hydrogen. So hydrogen is excreted through the urine on the by riding ammonia, you can tell. So hydrogen is excreted in the urine as a form of ammonium. One form is ammonium, and if you decrease the ammonia synthesis, there will be decreased ammonium, and there will be actually a decreased excretion of hydrogen. So it will also aggravate the situation. Okay. Next case 33. Here we have a 30-year-old male who have severe watery diarrhea. So and this patient also has an increased breathing rate, and he has some electrolyte disturbances. As you can see, the sodium is decreased, the chloride is increased, and the potassium is decreased. And can you tell me what is the most likely acid-base disorder this patient has developed? And can you explain why the increased breathing rate occurring in this patient? Okay, so let's go to the slide and let's get our answers. So first, this patient has developed a normal anion gap metabolic acidosis. Why is so? First of all, this patient has diarrhea, and in diarrhea you lost a lot of bicarbonate from your gastrointestinal tract. And one of the interesting thing is this loss of bicarbonate is actually replaced by another cation, which is chloride. And as you can remember from your previous slides, the chloride and bicarbonate together consist of the measured anions. So if one is replaced by another, ultimately the total concentration of measured anions are normal. And also total concentration of unmeasured anions will be normal, they won't be changed. So as chloride is a measured ion, there will be no rise of unmeasured anions. Okay, so there will be a normal anion gap acidosis. Okay, and as you have more acid in your blood, you want to lose some acids through your lungs. Okay, so if you want to lose some acid through your lungs, you actually do that by some exuding some volatile acid like carbon dioxide through your lungs. So you want to increase the breathing rate to increase the rate of excretion of acids. Okay, so this is the mechanism by which you can explain the increased breathing rate. And then we can actually know some other causes of normal anion metabolic acidosis apart from hypoaldosteronism and diarrhea, which are type 2 respiratory, type 2 renal tubular acidosis, and type 1 renal tubular acidosis. So in case of type 2 renal tubular acidosis, there is increased renal loss of bicarbonate like that of diarrhea, and in case of type 1 renal tubular acidosis, there will be failure of excretion of titratable acid such as phosphoric acid, and also failure of excretion of ammonia. You just remember the facts. Okay, next, suppose a patient came to you after severe vomiting episodes. Okay, and you did some electrolytes and he has some decreased serum potassium and decreased chloride, and you note that there is a decreased breathing rate which is about 9 breaths per minute. And can you tell me what is the most likely acid-base disorder this patient is having, and why did the respiration actually depressed in this patient? Okay, let's get our answers. So this patient is having metabolic alkalosis because he has lost a lot of acid from his stomach by vomiting. So there will be a relative increase in bicarbonate concentration leading to metabolic alkalosis. And if you have an increase in bicarbonate concentration, if you have an increase in alkali, you actually want to increase the acid to counter that increase, to actually get a balance. So to do so, you want to increase carbon dioxide concentration in your body, and you can do that by decreasing respiratory rate. So this is by decreased ventilation, you can increase the carbon dioxide concentration, and this can actually compete with bicarbonate. Okay, so this is the respiratory compensation for metabolic acidosis. And also you can also note that this patient also has dehydration because as he vomited, he lost a lot of fluid, and this loss of fluid will lead to dehydration. And this dehydration actually contributes to further alkalosis, and this happens as the patient is dehydrated. He will be a decreased blood pressure, and actually decreased blood pressure will lead to a decrease in renal blood flow. So the decrease in renal blood flow will actually activate the renin-angiotensin aldosterone system. So if you have an activated renin-angiotensin aldosterone system, there will be increased aldosterone. So increased aldosterone actually have many effects, and one of them is increased hydrogen excretion. So increased hydrogen excretion is something very bizarre in this case because you have already lost a lot of hydrogen in your body, from your body by vomiting, but still you are losing hydrogen from your urine or through your urine, and that actually occurs due to preferential conservation of sodium. Because if you have a volume contraction, the first thing you want to conserve is you want to conserve volume, and to do so, aldosterone actually does that by increasing sodium reabsorption in the distal tubule and actually conserve volume. But the cost it pays for doing that is actually it increases hydrogen excretion. So that's why you already have lost hydrogen and still you are losing hydrogen, and that's why it's called a paroxysmal aciduria. Okay, and angiotensin 2 also does some damage. It actually increases bicarbonate reabsorption in proximal tubule, but this is not its main effect. Its main effect is actually increase your blood pressure, increase your total peripheral resistance. Okay, so that helps to maintain the blood pressure. Okay, but another mechanism by which it actually increases the alkalosis is actually it increases the bicarbonate reabsorption from your proximal tubule, so it aggravates the alkalosis, and this is called a contraction alkalosis. Case study 5. Now we have a patient, a 50-year-old male who has taken a large dose of an opiate, and he developed pinpoint pupil and a very low respiratory rate. So can you tell me what is the most likely acid-base disorder this person has developed? Okay, very good. So this person has developed a respiratory acidosis, because when someone takes opioid or any drugs that actually depress the respiratory center in the medulla, it will actually cause a decreased respiratory rate, and when you have a decreased respiratory rate, you can't lose a lot of carbon dioxide through lungs, so there will be decreased level of loss of carbon dioxide through lungs. So carbon dioxide will actually build up in your body, and carbon dioxide is a respiratory acid, so you will have a respiratory acidosis. Okay, so those are the explanations. And there are some other causes of respiratory alkalosis, acidosis. Sorry, I have mistakenly so this is not respiratory alkalosis, this will be respiratory acidosis. Sorry for that mistake. Okay, so there are other causes of respiratory acidosis, which are sedatives, which are also act by the same mechanism. It depresses the medullary respiratory center. Anesthetic, same mechanism. And those diseases such as GBS, polio, ALS, amyotrophic lateral sclerosis or multiple sclerosis all act by actually paralyzing your respiratory muscles. So if your respiratory muscles are paralyzed, you can't take a breath and you can't actually excrete a lot of carbon dioxide. So carbon dioxide will build up in your body, in your blood, and it will lead to respiratory acidosis. And airway obstruction will also cause the same thing. You will have a decreased level of carbon dioxide excretion from your lungs, leading to respiratory acidosis. So we have our case 6, and this case is a 16-year-old girl who presented with very high respiratory rate, and she has a history of family conflict. Okay, and can you tell me what is the most likely acid-base disorder that this girl will develop? Very good. This girl will actually develop respiratory alkalosis because she has a very high respiratory rate. She will lose a lot of carbon dioxide. So she will lose a lot of carbon dioxide from her lungs, and this loss will actually lead to a decrease in carbon dioxide in the blood. So if you have a decrease in carbon dioxide, which is a respiratory acid, you will have alkalosis. So it will be a respiratory alkalosis. And actually you can remember from your previous slide that if you have a respiratory alkalosis, you actually want to lose more alkali. So if you have a decrease in carbon dioxide, you want to have a decrease in bicarbonate also, and you can do that by actually increasing the excretion of carbon dioxide through your kidneys. Okay, and you can do that by decreasing the reabsorption of kidneys. So concepts that I have already talked about in previous slides. And respiratory alkalosis can also occur in pneumonia, in pulmonary embolism, high altitude, and some other causes. The mechanism by which in pneumonia and pulmonary embolism respiratory alkalosis occurs is if someone has pneumonia or pulmonary embolism, he will have a sudden hypoxia. And this sudden hypoxia will actually lead to stimulation of the respiratory center, and he will have hyperventilation. And if someone hyperventilates, there will be increased excretion or increased loss of carbon dioxide through his lungs. And the same thing occurs in high altitude. If someone is in high altitude where there is a decreased partial pressure of oxygen in high altitude, there will be hypoxemia, which will lead to stimulation of the respiratory center, leading to increased loss of carbon dioxide. And I have already mentioned a case. In this case, I previously talked about, it was a case of hysteric hyperventilation. So it is a psychogenic stimulation. There is psychogenic stimulation of the medullary center of respiration, leading to hyperventilation and also ultimately leading to respiratory alkalosis. And salicylate intoxication or aspirin intoxication. In case of salicylate, the primary disturbance is salicylate actually can stimulate by itself directly the respiratory center in the medulla, and by that it actually causes hyperventilation and actually leads to increased excretion of carbon dioxide, leading to respiratory alkalosis. Okay, so this is our last case, case 7. So this is the best case, I think. Here you have a 25-year-old male who have an overdose of aspirin. And can you tell me what is the most likely acid-base disorder he will develop first? And if we don't treat him, what else can develop? Okay, so let's get our answer. First of all, at first the patient will develop respiratory alkalosis. And I have already mentioned previously that salicylate or aspirin actually directly stimulates the medullary respiratory center, and that causes a hyperventilation, leading to a loss of carbon dioxide, and a loss of carbon dioxide or a loss of acid will cause a respiratory alkalosis. But if you don't treat that patient promptly, this salicylate will ultimately go on, accumulate in your body, and it will actually inhibit the Krebs cycle and causes a severe uncoupling of the oxidative phosphorylation. So oxidative phosphorylation is actually aerobic metabolism. So if you can't metabolize your metabolic substrates through aerobic metabolism, you will actually go on to produce energy through anaerobic mechanisms. So the most important product or the most common product of anaerobic metabolism is lactate. So you will have a buildup of lactate in your cells, and which will ultimately come to the blood and ultimately cause a metabolic acidosis. So in a untreated patient of aspirin, pH is commonly increased because the primary disturbance is a respiratory alkalosis. So the partial pressure of carbon dioxide will be low because you will have lost a lot of already lost a lot of carbon dioxide from your lungs through hyperventilation. But ultimately you will have a decrease in bicarbonate also because you have developed a lactic acidosis. Okay, so that's all from me. Those are the most basic concepts that I think everybody should remember. Actually, to get a good grab of acid-base disorder, you have to come back and repeat it or review it for multiple times, because this concept sometimes is mesmerizing or confusing. So that's why you have to repeat it and actually build the conception, ingrain the basic rules. So basic rules are bicarbonate for metabolic problems, carbon dioxide for respiratory problems, and bicarbonate and carbon dioxide go up or go down together. Okay, so those are the most important things that I think someone should know and remember for metabolic disorders, acid-base disorders. Thanks all for watching my video. Okay, and stay tuned for more.